Certificate in Medical Genetics. Dr. Shagun Aggarwal has played a pivotal role in professional genomics society and for the Academy of Medical Genetics in 2022. She currently also is the chairperson of this group, and she also extends her work internationally as she's a member of the International Field Sequencing Consortium, which is an effort of involving 20 nations internationally. She's a geneticist specialist and provides in continuous care for patient diagnosis and counseling in this field and has over 100 publications. Next, I'd love to introduce Dr. Rajeshwari Reddy. She is one of the leading obstetrics and gynecologists and robotics surgeon in Hyderabad and has over 20 years of experience. She is somebody who is dynamic and conducts health camps and cancer screening as well, and I think comes with a lot of experience in various cultural dynamics as well as university. Last but not the least, I'd love to introduce Dr. Swapna. Dr. Swapna is the Vice President of the Indian Society of Gynecology and Reproductive Biology, thank you, chapter of Hyderabad. She's also received the Ratha 2015 award and has extensive experience, and we had a lovely chat earlier. Welcome, ma'am. Thank you so much. Thank you so much and welcome here. I'm very excited and thrilled to have a conversation with all of you. So I think I'd like to start with some of the very basic questions, but I think very important questions to address on human pregnancy losses. So I'd like to start with you, Dr. Swapna, is if you can help us understand some of the common causes of recurrent pregnancy losses and what and when do you do this workup for these cases?
Yeah. So that's a very long answer you've asked me. I feel like I'm sitting in my viva. Good morning to the audience. You can go to sleep while my answer is going on. So when we talk about the common causes of recurrent pregnancy losses, we have to differentiate it from sporadic pregnancy losses. And after you leave out the sporadic, and again, if we talk about recurrent pregnancy losses, we are talking about 2 pregnancies or 3 pregnancies. In my practice, I like to do the evaluations after 2 pregnancy losses. And most of the commonest early first trimester pregnancy losses are definitely endocarditis, fetal endocarditis. Then you have the uterine factors, then you have the infections, then you have the immunity, then you have the genetics. So each one there are multiple reasons. The uterine factors, you have the inherited, which is the uterine fusion anomalies, and the mythical unicorn of cervical incompetence. I call it the mythical unicorn because you never know whether it's real or not, and how do you show it, and are you seeing a horse or a unicorn. Then you have the in the Mullerian fusion anomalies. Again, you have the different classifications. I think all the names have changed, but your own work, so I'll still stick to the old names of a bicoordinate uterus, a septate, a arcuate, a unicornate, a diadelphys. Then you have again the archaic, is it there, is it not there? Then you have of course the cervical incompetence. There are new RCOG guidelines on that which I think would help us handle our cases better. To put the stage, not put the stage, the progesterone, which progesterone, that happens with the cervical incompetence. Then you have the acquired uterine causes which are Rashomon syndrome. Then now what has become very popular is the lateral metroplasty, is a very small T-shaped uterus, so does that lead to recurrent pregnancy loss? Then of course the Rashomon syndrome, you have these fibrotic bands which decrease the amount of space to be occupied, which when you cut them also might not have enough endometrium left, and what is left might not have enough vascularization because of the fibrosis. Then you have the endometrial polyps to remove, not to remove. I always say remove before conception. Then you have the fibroids, now submucous fibroids, intramural, subserous. Subserous is fine, but submucous, distorted cavity, not distorted cavity. So you have all these are the uterine factors. Then you also have the endometrial factors and the natural killer cells present there, the cytokines present there, which we do we test, how do we test, what are the lab standardizations for it, regular blood tests, or as I said, is anybody sleeping?
No.
Yeah. Then we have the infections now. I think the infections are more in vogue for the second trimester losses rather than the first trimester losses. Then of course the autoimmunity, the inherited thrombophilias and the acquired thrombophilias, the APRA syndromes, and how much do we test for these. Again, some of these are under contention. Then the body weight, the habits, drinking alcohol, smoking, having fun, lots of fun. The BMIs too, you have to be the ideal BMI apparently. We all are categorized into ideal and non-ideal. If you're too skinny also less than 90, not good for having babies. If you're too fat also more than 25, not good for having babies and implicated in recurrent pregnancy losses. So, anything I've left out? Endocrine, of course, yes, thank you. Rajeshwari, thank you for giving me the answer. I'm cheating now. So the endocrine factors, of course, the thyroid peroxidase antibodies, the diabetes, the prolactin, do you do prolactin or not? I like to do my prolactin. So the prolactin and of course diabetes. We have non-diagnosed diabetes, which is now becoming rampant, Hyderabad being the diabetic capital of the world. Yeah, we're all obese now. We're all pre-diabetic. Young girls with diabetes. Then of course PCOD, to do or not to do again is a contention, but yeah, definitely high LH, I think they do need a little support. Then again the mythical nucleus defect. They are not there, test, not test. Again, I think the guidelines say something, then every guideline in every country does not agree with treating these. I think these you fine tune to your practice and your patients and what they expect from you. So I think I'm done.
Thank you. No, I agree that I think there's a lot that we know, a lot that we don't know, a lot that we're still debating on.
Yeah, so I've not touched the genetic factors because you touched a lot of those already.
So a follow-up question to that which you mentioned is that you generally work these up when it's a 2 pregnancy loss. So what?
3.
Yeah.
So I do after 2 pregnancy losses. But I also have patients who wait on the career pathway and then who choose to get pregnant, who time their pregnancy and have 1 loss, and they're not happy about it. And a lot of my patients pay for themselves and then they say, can we test something? I tell them, these are all the tests, these might be the answers we get, and then if you're very keen, we can test. But with 1 loss, your chance of a live birth is very, very high. But if you still want to do the test, I would not deny them the test because they are paying for it themselves. So why not test it?
Sure, that makes sense. Thank you. Dr. Rajeshwari, I have a follow-up question with you. Is that, we talked a little bit about maternal infection. So what is the role that torch plays and how do we routinely test for these and what other tests when it comes to maternal infections would you consider?
Torch test definitely is a no, because once a person is infected with torch infection, there's already immunity developed, so that wouldn't cause recurrent abortion. So right now, according to the RCG guidelines, we don't do torch testing at all. So coming to other infections, we look for bacterial vaginosis or chlamydial infections. These generally cause second trimester abortions, but we don't really see them practically causing recurrent abortions because they are symptomatic and we treat them. We take a high vaginal swab and then we treat it completely before they go. So torch would not be a subject of discussion for recurrent pregnancy loss at all.
Thank you. Dr. Chinmayee, I wanted to ask you about genetic workup that you would do for recurrent pregnancy losses, especially after 2 or 3 steps. What's your take on that?
So, thank you for having me here. Before we start, I think one thing we all need to understand that recurrent pregnancy loss is a daunting problem for every clinician. The reason people are here on this Sunday, it's 1% of all reproductive couples who have recurrent pregnancy loss. And despite all that we will discuss here, despite all the ideas that we will give, literature remains the same from 9 to 2 p.m. today, that 50% of these will remain unexplained. And therefore, that is the first thing that we want to tell the parents before we start all this workup. We will do all these things, we will try and make it better for you, but 50% of the times we don't know whether this is going to happen or not. In terms of infection, I think I just like one follow-up there, that most of these couples come to us for counseling when they are pre-conceptional for the next pregnancy. So when we do not do the torch with regard to repeated pregnancy losses, we definitely do a rubella IgG test, because that is a preventable infection, and in any case you're looking at this woman as a pre-conceptional woman. You're looking at her to optimize the next pregnancy. So doing a rubella IgG is something we recommend. If it is negative, then offer her the vaccination, following which 1 month she needs to avoid the pregnancy. In terms of genetics, I think the workup should start with the second loss, and the workup should start on the product of conception. Because on the product of conception, if you can prove a genetic cause, then that makes sense to work further. If we prove a genetic cause, which is like an aneuploidy, like Dr. Swapna just said, the commonest cause for that miscarriage is aneuploidy. We have read this. Because human reproduction, as it is actually written in literature, is one of the most inefficient reproductive processes. Almost 70% of conceived pregnancies don't go to live births, because we don't even detect them. Ever since we started looking at pregnancy tests, we started detecting biochemical pregnancies. But then there is almost a 70% failure rate for human reproduction. So if you can prove on the product of conception that what is the genetic cause, if at all. If it is normal, then you're not dealing with it at all. If it is abnormal and it is an aneuploidy and the parents are normal, then this is a one-time event which is probably a non-disjunction, and it's probably not going to recur or recur at a sporadic rate at whatever it happens. If, however, it is an unbalanced translocation, and that is cause for testing the parents, and if you find unbalanced translocation in the product of conception, then you go ahead and test the parents. The choice of test, I think Dr. Shagun will be elaborating it there, because there is a little trick here that you do a microarray on the product of conception, but you do a karyotype in the parents. We had problems where people have done microarrays on the parents, proven that it is normal, told them it will not happen again, and then we had problems again. So that is where the clinicians need to understand the difference between a microarray and a karyotype and their role in recurrent pregnancy loss. So in terms of genetic testing, I will start with the product of conception. Getting a clue from that product of conception, I will move on to the parents. This is what is literature as of now. But then there is a lot of emerging literature about doing genetic testing in the woman herself to look for mutations which put her, but all your LC events will then come there. Because if you prove today, they are doing all these Mapmygenome pathways and everything, that's my hesitation about doing that. That in case somebody has a gene which predisposes her to have recurrent pregnancy losses? Is it going to affect her marital consequences? Is it going to affect her life consequences? Things like that. But I'll start there and stop there at this moment.
So, one thing, as you said, now we are picking up 50%. But I think if more and more people agree for products of conception testing, because there is a lot of pushback when you say do the testing of POC, then we might pick up more number because of genetic factors. That I strongly believe in. Because a lot more of my patients are accepting this now. Because as I said, everybody seems to be on a very tight schedule now. And because they are paying for themselves, they are curious. Not only counseling them, it helps in understanding why this happened, it also gives us a pathway to follow for the planning the next one.
And any positive result actually gives a kind of closure to the
Yes.
patients.
And also, recurrent pregnancy losses is a lot of emotional load to carry, a negative load to carry. And we are doing more and more testing in our parents also. They come forward and they are agreeing. Again, Dr. Shagun has to teach us what test to ask for. But I am finding a lot of MDHFR mutations and so many other thrombophilia mutations in people with no previous histories, traumatic event histories, and definitely putting them on aspirin and low molecular weight heparin is leading to a good live birth outcome. But again, if you ask me and somebody stands up and says, what is the proof? There are no RCTs for this. How morally you would RCT this? So clinically, yes.
To understand
Yes.
recurrent pregnancy loss, stillbirth, a lot of these problems we will never have RCT.
You can't have
It is not
RCT.
possible to design an RCT for that.
Yes.
So most of the evidence that will come from will be from case series report,
Yes.
and which will then be put together in a systematic
Yes.
analysis where you can generate some evidence.
Correct.
But you can't have.
So what would help is if you made the language and the test similar, so that you can put case studies all over the world together to get a systemic analysis. Because when you try and do it, the reporting, the testing, the language is all different and you don't get a pooled sample to give you a result. So that is probably something the guidelines need to work on rather than saying do this and don't do this.
Most of the time, patients, they are not aware that this product of conception testing, cytogenetic testing will give 90% of the information and the karyotyping will just give only 2% information. So the counseling part, when people see they have a spontaneous abortion at home or it's not accessible, it's a different story. But when patients come to our OPD and then we have a ultrasound saying it's a miscarriage, we have to do a detailed counseling and inform them how this is much more important than all the other tests that we will do for a recurrent pregnancy loss. And I think that is the way to go about it.
So now, taking after Rajeshwari Reddy, this is addressed to Anu. The cost is a limiting factor.
We are reducing all of it.
We're working on it.
Thank you.
Shagun, a follow-up question to that. I definitely agree that I think in practice we do see a lot of couples coming in where parental CME is done, but unfortunately the CME of the POC is not done. And then I also agree that, for unexplained pregnancy losses, the closure is such a huge burden, right? So most of those couples come and ask this question is, can you do any testing on me? So what is your take on RPL panels or whole exome for the couple wherein they've not found any answers?
Going on to what you're asking, so just to what the discussion has just happened. So there are two aspects here. Although yes, now RCOG says that we should be doing the POC cytogenetic testing, but I have a different take on it, and I think those guidelines we need to also see from our Indian lens. That's very important. So practically doing the POC microarray, it would give you an answer in, as Dr. Rajeshwari mentioned, in around 90% cases. Out of these 90%, there would be a significant proportion, let's say around 40 to 50%, where there would be a sporadic aneuploidy actually. And that does give you an answer for that loss, but that doesn't explain your RPL. Okay, so it's useful, yes, for a closure, for getting an answer for that pregnancy loss, but actually it is not something which gives you you an answer for the RPL and it doesn't really help you in guiding the couple for the next pregnancy. So we can adopt that, especially in a private sector if the patient is affording, but then there are a lot of issues like patient aborting at home, the maternal tissue getting mixed up and then the result coming up as an MCC in the POC sample. So if we are really looking at finding the cause of RPL, we should step back and we should try to focus on doing a basic couple karyotype, because that is where you would find the recurrence, the reason for the recurrence, the genetic reason for the recurrence. Because in sporadic aneuploidy, you will find in 40 to 50% of miscarriages, even if it is some other acquired factor, there could be still aneuploidy in the abortus. So 40 to 50% of any abortus will give you a genetic reason, first trimester miscarriage. That doesn't explain your RPL. So RPL due to genetic reason is there when the couple has a rearrangement. So a balanced chromosomal rearrangement, which as Dr. Chinmayee was mentioning, that basically you will not pick that up on microarray. So Dr. Salish also told in his talk. So a microarray is a test which just tells us if the DNA is having any imbalance. So is some part of a chromosome broken or missing? Is some part extra? So is some of the DNA missing or extra? That's all a microarray tells. It does not tell us if the DNA is rearranged or is it translocated, is it inverted, is the chromosome having an abnormal morphology in terms of a rearrangement. So that does, and that is what causes the RPL. Okay, so that is something which you not pick up in a microarray, only a karyotype is going to tell you. You had anything to add? So only doing a couple karyotype is going to tell you whether one of the partner has a translocation of a chromosome or an inversion in a chromosome, and then if something like that is there, so this will be there only in 3 to 5% couples. So a genetic cause of RPL actually is there in only 3 to 5% couples as of the current existing medical evidence we have. The rest of the causes, yes, in the POC you will find a genetic cause, but majority of it is just a sporadic aneuploidy. It is not going to recur. So we, at least in our practice, because I'm sitting in a public health hospital, our patients are not that affording that they keep on doing microarray of the POCs, and it doesn't really make sense if I'm doing workup for RPL. So for us, the first line test still remains doing a couple karyotype. And then despite doing everything, suppose I ruled out all acquired etiologies, I have done a couple karyotype, nothing is found, and in fact then we do go ahead and nowadays do offer inherited thrombophilia testing, although again there is no recommendation or guidelines saying that, but we also are seeing some cases whereby yes, we do find something and these couples are benefiting from thromboprophylaxis. We do that, but despite that there are cases which are remaining unexplained. Then those are the cases where actually we are offering microarray on the POC, and there the yield is 2%. So the yield for, what is that yield for 2% I'm talking about? That is something is that some couples have such small translocations that they will not be seen on a karyotype. So these are the couples where everything is coming normal, all investigation is normal. There now when I do the CME on the POC, I will pick up that yes, one of the partner has some cryptic translocation or a cryptic rearrangement, and that is causing the RPL in this case. So this is the logical, at least what in the logical flow which should go. We should rule out acquired etiologies, we should do a couple karyotype, and then if we don't find anything, then the next step could be a POC microarray, because all said and done we have to look at the expense also. So a microarray is going to cost, especially when I'm wanting to look for very small abnormalities, I would want to do the 750K microarray, not the 315K. And that cost around 50,000 in our, as of now, I'm not sure Mapmygenome how much they're giving it for, but that's the price. So a simple karyotype costs around 1,500 rupees. So that's it. Doing a couple karyotype, 3,000, you are finding 3 to 5% couples where the genetic factor is the cause of RPL. Doing a POC microarray is not the first time test in our setting. Yes, the RCOG guidelines are there, but the guidelines are appropriate for their country, because we need to remember they have a crunch in the manpower. We have a crunch in technology.
I just want to make a point here, Shagun. See, that's fine with the public health perspective, but when you are a private practitioner sitting somewhere, or you are anybody where the lady has had a miscarriage, doing a POC testing for the first time gives you two answers. One, whether or not it is chromosomal at all. So if it is chromosomal, then what type of chromosomal will give you a guide whether it could be recurrent at some point in time, or it could be a one-odd thing like you said. But the fact that it was that one-odd thing, aneuploidy, what you found, because again we cannot be looking at investigations for RPL in silos. Because we are in a genetic forum right now, we are like so concentrated on the genetic forum that we've forgotten about the other aspects. But what if we did not detect that this was because of an aneuploidy? And even aneuploidy sporadically can happen twice.
Yes.
So suppose somebody had two miscarriages and one of them was trisomy 17 or one of them was monosomy 5 for whatever reasons. She does not need to have the whole gene bank what Dr. Swapna was suggesting, because otherwise she becomes unexplained RPL, and then you have to start from uterine factors to, now uterus also does not stop at just uterus, no? You all have now made so many definitions of the uterine cavity, of this and that and the other. So then if you know that both the times there was an inherent chromosomal abnormality because of which the fetus did not grow, you can absorb this woman of all other tests for the time being. I can't say that after 2 years you'll again find that she has some acquired thermophilia or something else in the background. But I think testing the POC makes sense. And cost is always a relative option. And labs are keen on getting down the cost, that's very good for us. But then otherwise also, for every woman, I think I would give that option. If she wants to test it, let her test it. Let's have the information.
Yeah.
I would prefer, I mean, like.
I'm not dissing that, but yes, I think options have to be given, information has to be given, and a shared decision making. Always I feel that the couple have to be partners in making a decision of where they will spend their money and how they will spend their money.
All pregnancies that we are seeing now are so ridden with stress.
Yes.
And when there is a miscarriage, the whole counseling while there is we detect the miscarriage on the scan, that counseling.
Yes.
Then the obstetrician talks to them, that counseling. Then when she's undergoing the procedure,
Yes.
before she's discharged, they just want answers.
Yes, and telling the parents, to normal looking, active, successful parents, let us do your quarantine. Not a lot of acceptance on that.
Takes a while.
Yeah, they just look at me like I'm talking out of my hat. And like, you're fine, what are you talking about? And the next day they will go to Rajeshwari. So, yeah, that happens. So doing the product POC, sometimes also gives us a gateway. Okay, nothing has come in this, but maybe there is something in you. Then they become a little more open. That's what we find with the.
That's okay. I think our game is about the efficiency. Correct. For us, it's like each patient is a different patient.
So it depends on the system you're in. As you said, NHS has the Green Dot guidelines are for UK and the NHS where they're using their money and of course the lack of their manpower. But here, what of us sitting here today are in private practice. So they don't want to, because they're looking at us to give them answers. Tell me what to do next time. Tell me why this happened. I want to know why this happened.
So that's what, so as I said, no, that doing the POC test, yes, gives us an answer, gives us a closure. But then, even if you're finding, maybe say one miscarriage of chromosomal 5, next you're finding something, it is not translating into any action, except for the fact that yes, you probably may not go on to the extent of doing a uterine anatomy workup. But still you would
No, we are not purely doing this. We are also going to test them for amplifiers, sustained vitamins, everything else. We are going to give them lifestyle changes. We are going to evaluate the uterus. This is not the only test we are getting.
Yes, of course. But what I'm trying to say is that even if you find something in the microarray, let's say we found that the fetus had monosomy 5.
Yes.
still would you not want to do the acquired workup? You
Yes,
would do.
absolutely, yes.
So that's my whole point, that
Yes.
you know, you do this also and then
Yes.
you have to do the acquired
Immediately you have to do everything
So
else,
why
yes.
not do the acquired workup and the parental karyotype, and then, you know, what I do is that I bank the DNA. Because couple, as you're saying, yes, couples do want an answer, so they say, please do POC testing. I say, let's store this DNA, let's first finish the basic thing, and yes, if we don't find anything, we will use this to do further testing.
So you are the geneticist and I am the clinician. So telling them next door to bank the DNA is not going to happen in the clinical practice.
I get it, so a lot of practice.
And miscarriage is a very difficult time for the whole family. And unless you close that event and move on,
That's
we do the banking of the DNA in terms of fetal anomalies or something like that, because you know, by that time they have reached a point where they've seen a baby moving inside, they've seen things like that, their approach towards the next pregnancy is different. But in a miscarriage where they have not actually seen this woman being pregnant by the social standards,
Yeah.
and they've just seen, okay, something came and then it went off. So much so that when we tell them they've had a miscarriage, the next time they come for the heart echo, because they say, last time madam, there was a heart problem. What was the heart problem? At 6 weeks, the heart stopped. Now, you know, how we look at a particular condition and how patients look at a particular condition
Yes.
is completely different. So at that time, you know, we all actually chuckled here. No offense, but then for that patient, the baby's heart had a problem.
Yes.
So she has come for an echo this time. That is why, you know, sometimes and especially recurrent pregnancy loss, you know, finally what is the evidence-based treatment of recurrent pregnancy loss which no one has contested till now? Echospin is contested.
Tender loving care.
Tender loving care.
That is also contested.
That is love is contested. No, but the point is, that is where we all come down to. And so, at some point, we need to give way and do
You
things.
are rushing and giving Neeraja's final question answers.
Over to you. No, that's only fine. But
I do agree with all of this, because I do agree with Dr. Shagun. What you're saying is that I think we have to put together the financial situation, the consent of the patient, and then, you know, how much information is the information they are seeking, how much is not too much for them. That's very important, right? So I think we definitely see all of these happening in the clinic, and I agree that there is a lot of differences in practice, obviously because we don't have a lot of evidence in what we can do. And then, of course, public versus private practice in India becomes very different because of who's paying for it at the end of the day, right? So to forward on that, I have two questions for you, Dr. Shagun, to follow up is one, what is your take on RPM panels, which is again very debated, right, clinically and scientifically, and whole exome sequencing on couples, because many of these guys will come in and say it's unexplained, I want an answer, I want to make sure that the next pregnancy is okay, and I definitely agree. I think the timelines of pregnancy become so tight now.
Yes.
And you know, that's again one of the reasons why there is so much push. And I think us as genetic counselors, we very much see these unexplained pregnancy losses coming back and saying, can we do something more? Can we do something more? So the first question I always ask is, how much more is okay for you? So what's your take on that?
I'm not sure what you mean by that IPA panel.
So there are a set of genes that are being
sequenced and being offered as an
being
IPA panel.
offered, because again, the data is questionable.
Yes.
We don't have a lot of evidence. And my major concern with all of these genes are the utility. Even if we know, like you rightly pointed out, predispositions, we know predisposition, how are we going to utilize this without making sure the lady does not feel stigmatized or, you know, burdened about carrying a predisposition at the end.
So, yeah, that's right. So all this evidence about any single gene contribution towards RPL is still emerging. That's the, that's the thing which is to be underlined. It's emerging. There is no scientific evidence or clear-cut, proof as of now that there is any single gene contribution towards RPL. It could, and this we are talking about a first trimester mismatch, okay? But when we move on to a second trimester loss, then yes, then there is a contribution of single gene disorders in second trimester losses, which are basically all those fetuses which most of the times turn up with an anomaly in scan. So that also comes under the definition of RPL. So those late RPLs, yes, once you have ruled out the chromosomal abnormalities, I'm talking about from the genetic perspective, so you have ruled out the balance rearrangement in the parent, and you had history of a late pregnancy loss where at least there was an anomaly or maybe other findings like height drops or maybe some arthrogryposis or some short bone suggesting a skeletal dysplasias. Those coupled, definitely there is a role for testing for single gene conditions. So whereby all these sequencing technologies come in. So again, the ideal would be, ideal is always which is never achieved, is that we should have the fetal sample with us, which hardly ever happens in India. I mean, conserving the fetal samples is not something which couples at that point of time when they have undergone that miscarriage, they are not ready for it basically. It doesn't happen. So often that's not there. So that's when we don't have the fetal sample, we resort to the point whereby we are doing the couple sequencing now. So again, doing the couple sequencing, we do not want to do an RPL panel or for that matter any panel. There are so many screening panels, carrier screening panels, RPL panels, infertility panels which are available. There is no clear-cut scientific basis or evidence saying that this is the right gene to put in that panel. So we should not be talking about doing all these kind of panels. But what we can do is an exome sequencing for the couple. Again, for first trimester miscarriages, there is no hope of doing a couple exome sequencing because we are not going to find anything as of now. Current literature evidence says that. But in second trimester losses, at least if you have a morphological abnormalities or other situations I described, there you could opt for a couple exome sequencing, whereby what we are looking at is are couple carriers of any autosomal recessive disorders or mom carrier of an X-linked recessive disorder, which could match with the phenotype of the affected fetus. So here again the phenotyping is very important. If you just had an unexplained second trimester loss, you don't have any other information, then I would not prefer to offer such a test because all these technologies doing exome sequencing, it is such a powerful technology, it will sequence all the genes of that couple. It is going to throw up some 20,000 genetic variants. And unless I know what disease I am looking for in those variants, majority of these variants are actually going to be just polymorphisms. They are not disease causing. So getting a report like that, and then very often the labs also are forced to give sometimes reports whereby they have to report these variants as all variants of uncertain significance, and then you are in a huge fix. A couple comes and there is a long 10 genes list, some 10 variants are listed, all variants of uncertain significance. You have nothing to work upon, and then they are suddenly in a fix that what is this, what is wrong with us. There is so much of psychological trauma, so many things involved here.
I think one thing that we have to make clear here when we are talking of exome sequencing of the parents, are we talking of exome sequencing because of what has affected the fetus, or also a possibility of the mother carrying genes which predisposes her to like thrombophobia-like conditions, in which case the fetus will not have anything. It will just be her inability to carry that pregnancy forward. And if that happens, then we are moving away from that realm of donor oocytes to again, carriers, which again becomes another conflicting period where she might need a surrogate because she does not have the ability to carry the pregnancy forward. But all these are still...
So again, inherited thrombophilia, again, as of now there is no recommendation that we should be testing for first trimester losses also. For second trimester losses or unexplained IUDs, yes, we do if there is some evidence of uteroplacental insufficiency.
But when you do a whole exome,
yes, but not as part of a full exome, right? No, not as part of a full exome, as a separate targeted inherited thrombophilia testing. In the scenario where you have a documented uteroplacental insufficiency kind of clinical picture with no other reason for that.
then you are specifically looking for
Yes, an inherited thrombophilia, but not really as part of whole exome. Another scenario, I think what you mentioned is that suppose a mom has a mutation, so the only again proven scenario which there is a lady who is having a recurrent molar pregnancy. So there are women who are prone to have this recurrent molar pregnancy because they are carrying a particular genetic mutation. So that is the only, again, the scientifically proven scenario where doing an exome sequencing for a first trimester loss makes sense, and then you would do it only for the mom. There is no role of doing it for the partner. So for first trimester miscarriages, couple exome sequencing or any RPL panel, as of now there is no evidence to say that we should be doing anything like that. It could cause more harm than benefit to the couple. For a scenario where there is a recurrent molar pregnancy, there you could offer the mother exome sequencing, because those patients who do have that particular mutations, they are at 100% risk of having a molar pregnancy. So that lady has to go for a donor ovum. There is no other way out for her. So that is one scenario. And then second trimester losses, yes. Again, if it is something in a setting of uteroplacental insufficiency, I would like to do a targeted inherited thrombophilia panel for the mom. If you have a documented scan in morphological abnormality or other scenarios like hydrops, arthrogryposis, scalpel dysplasia, then couple exome sequencing is the way to go. So you would really have to basically, the thing is to ascertain the history needs to be really good.
The history of the complete workup, because I remember one case which I think you only worked up for us. This was a case with multiple intrauterine fetal deaths somewhere in the second to third trimester, and everything had been worked up. So that the third or fourth time whenever she had it, you had done the autopsy, I still remember, long time back. And they had found some difference in the aorta, the calcification in the aorta, which was an autopsy finding, following which the exome was done on the fetus, and we found a homozygous combination for a gene which causes calcification of the aorta. And then we found the parents to be carriers, and then they did a CBS the next time. It was normal, and that baby was good. So again, second trimester and third trimester losses, I think we don't have to look at them at the same lens as for what we are talking about, recurrent pregnancy loss, because a lot of workup is wanting there. If it's done correctly, you'll find answers. First trimester losses are a completely different ballgame. Looking for answers is a huge challenge.
I definitely agree, and I think even for the lab's perspective, when you're doing genetic testing without having a complete workup, whether first or second, makes it extremely challenging, because you end up with those cases, you can't correlate them, and neither can you not report some of this, right? So that makes it very difficult. So another question on that is the utilization of PGT, especially for couples who've had a balanced transfusion. So because the recurrence rate in these couples are very high, given the balanced translocation, and some of them can be difficult to assess as well, what is the approach, and as well as what is the uptake of the PGT in those cases?
Okay. So what you mentioned, the recurrence risk is high, so I'll give a figure to that. It's around 25 to 30%. So even if one of the partner has a translocation or an inversion or any other chromosomal rearrangement, it's not that they are always going to end up with a miscarriage. Okay? Even if we don't do anything, 50%, the next pregnancy of such a couple, there is a 50% chance that it would result in a normal newborn. Okay, so we get very this thing that they have a balanced rearrangement as if it's the end of the world. There is nothing like that. So even if we don't do anything, 50% chance is there that the next baby is going to be fine. So what about the rest 50%? So the rest 50%, in that 25 to 30% chance is there that the pregnancy would end up in a miscarriage, and the rest of whatever remains at around 15%, that is something that maybe you may find some abnormality on scan, or if they do not do anything, a baby will be born who will have a malformation or maybe intellectual handicap. So basically what I'm trying to say is, if you find a couple with a chromosomal abnormality, whereby basically we are talking about the balanced abnormality like a translocation or an inversion, then also 50 to 60% chance of a normal pregnancy outcome is there without any intervention. The rest, 40 to 50%, comprises of various outcomes, starting from in fact subfertility, which is like a preclinical pregnancy loss kind of a scenario, to miscarriage, the tune of which is 25 to 30%, to if the baby survives the early pregnancy, then maybe something gets picked up on scan, to if that also is missed, maybe a baby is born. So all these outcomes are possible for this couple. So we should again straight away not jump on PGT. So if you have a younger couple, probably you ascertain the rearrangement after 2 pregnancy loss itself. you can still give them option for planning a spontaneous pregnancy. They can go ahead with a spontaneous pregnancy. If they pass the first trimester, then you offer them an invasive testing in the form of an amniocentesis or even a CVS. Do a microarray and check whether the fetus has any kind of chromosomal imbalance resulting from the parental abnormality. If that is ruled out, then you're as good as any other pregnancy. So for a younger couple with ascertained due to maybe 2 or 3 losses, this would be a great option. Other option, of course, which we again discussed, is PGT. So, but for PGT, the couple has to go for an IVF. There may be no other indication for doing an IVF, right? I mean, you're just doing an IVF because you want to do a PGT. I mean, it doesn't make sense. So we need to see the scenario. So if suppose, yes, it's a little elderly couple, they've already suffered many pregnancy losses, maybe 4 or 5, or you gave them a trial of spontaneous pregnancy after you ascertain the abnormalities and they're still landing with abortions, then yes, then that couple can be encouraged to go for an IVF and do PGT. And then by doing PGT, you would rule out, you would discard those embryos where the chromosomal abnormality happened, select the ones which are chromosomally balanced, and then implant them and go ahead. That would definitely improve the pregnancy rate for that couple. So it has to be scenario based.
Yeah, so, Dr. Shagun explained very well what are the percentages. So I always think that this has the choice of how to proceed next has to be a group discussion and teamwork. Who is to say that a young couple are okay having an amniocentesis, waiting for the report and then doing a miscarriage?
Definitely.
I have patients who are not willing to go to that, and then, so I think we should not put words into the patient's mouth. I as a clinician will do the test, then I will send them to you guys for the genetic counseling, and then they come back to me again to close the circle and discuss their options. I think as a clinician, we give them the options, the pros and cons of each one. Yes, 50% can be normal. You can try spontaneous conception. You might be in the normal group, and then the pregnancy will continue, and it is fantastic. But you can do CVS, you can do amniocentesis, you wait until all that time you don't know if the baby is good or not. And then if you think the baby is not good, then you undergo second trimester termination of pregnancy, which is all emotionally, financially, all, this is the downside of the spontaneous thing, but this is what you have to go through. Otherwise, you don't want to go through all this, you just want a perfect baby. The downside is the procedures they have to go through, again the financial. So basically there is no free ride.
There is really no free.
There is no free ride. Whether you want this ride or you want that ride, I think without any prejudice from us, whether they are rich, they are poor, they are young, they have had multiple miscarriages or not, without our prejudice, I think our job is to give them the options. Young couple, old couple, I don't think makes any difference. I disagree with you on that. It is their emotional status and what is okay for that couple.
I think it's the perception of burden that we
Yes,
from
yes. I think the choice should be given to them, and whatever they choose, non-judgmentally we say, all right, I will send you to the next step, and this is what we will do.
No, I agree with you. So that's true. The option has to be there.
And without prejudice from us, we have to give them the
The
options.
25% risk for a couple may be high, but the same
Yes.
may go for another couple.
Yes,
That's
yes.
a personal choice they make.
Yes.
At the end of the day. Okay, okay.
I have a small follow-up question on that. If I in some cases like Huntington's chorea, anything which there's no option as such. So in that case, either the patient has to go for IVF and go for PGT, so that the abnormal embryo can be ruled out, or the patient can go for the pregnancy and then the baby can be tested, prenatally for the mutation using polyclonal. So which approach do clinicians prefer in that case?
Again, I think
This is not what clinician prefers, this is what the patient would want to prefer.
How can we decide? I mean, at least in our practice, we
You don't get enough to decide on your own.
I don't think you will understand that much. Again, this is Shagun's last question. Social, cultural, financial implications, right?
But the point is that both options are viable, right? You could offer both the options.
And you're not preclude the other. Like if you see Huntington's disease and you find it in the PGT, then probably you are discarding the embryo. If you don't find it, then you put it, you implant it. But at the same time, you still recommend a prenatal test. The chance of finding it in the prenatal test are less. But she has to be followed up by a prenatal test.
And the test there will not be exome sequencing because it's a repeat expansion.
It's like a science sequencing.
Yes, so DPPCR, not triple sinus sequencing.
Follow up on different tangent. I mean, you've talked a lot about genetics, so I would like to talk a little bit about lifestyle factors. Dr. Rajeshwari, I'd like to ask you this: is lifestyle factors. So with RPL and with, of course, we've discussed with a lot of patients about, their lifestyles and their concerns that they bring up. What do you think are the top, things that you would tell them about what factors would reduce or increase the risk of RPL? So how would you approach that? And also, what are your recommendations when somebody's coming with RPL aside from the medical workup?
Okay, so lifestyle definitely has a big role as much as supportive, part of the supportive therapy also. So when it comes to lifestyle, we divide it into sleep, food, supplements and exercise. So sleep is always something that most doctors do not put there so much, make it sound so important, but sleep is when the actual cellular repair happens. So we have to tell everybody to sleep at least 6 to 8 hours of undisturbed sleep and not to have blue light at least 1 to 2 hours before sleep. And when it comes to food, so food always has 3 things that patients need to keep in mind: the quality of food, the quantity of food and the timing of food. All these 3 are very important. And actually, instead of saying no processed food or no sugars or anything like that, I always tell people just if you go back to the basics of Indian kind of eating, actually our Indian thali, especially the South Indian thali, is perfect with the right amount of carbohydrate and the dal or whatever chicken, and there's a curd which is a probiotic, and there's a salad which is high on fiber. And the timing is also perfect, the way we are taught, breakfast at around 8 o'clock, lunch around 1 o'clock, and a snack around 4 o'clock. So this is a very ideal thing. So, we are just making them pay to tell what they're supposed to be doing, which is actually just the normal thing. So this whole concept about, antioxidants, avocados, and I don't know, these things don't, because then if I have to eat avocados, I don't know where I'll have to search. And I didn't hear about it until the last probably 6 or 7 years of my life. So we didn't do this kind of counseling in 2 tier towns. So that's all what I'm seeing in Hyderabad. So definitely food, I have nothing much to say. Indian food, no processed food, no food with tags and preservatives, and there's nothing like, no added sugar of course, but there's nothing like you cannot binge on a chocolate or something one fine day. It's just that moderation, how often you eat, how much you have to just limit it. So anything in moderation is absolutely fine. And of course, no smoking is definitely a no, and alcohol again moderation, but if they can stop it, well and good. And coffee, not to have more than 3 cups, and try to restrict it to 1 or 2 cups and not mugs at all. So that's about food. And of course, if you eat the right quality and the right quantity, but at a wrong time, then also it doesn't work, because the body metabolism starts winding down in the evening, so the major part has to finish before sunset. And also a lot of patients, we are telling them about obesity. So I request everybody, please don't make patients get obsessed about weight. So just tell them to be on the right track, as in eat on time, home cooked food, mind the calories, and Maybe an Indian dessert which is not 10 milligram of jaggery sugar.
We're lucky to have a good BMR like Rajeshwari.
Because I really feel very awkward making patients pay to say what I'm actually doing every day. So eating, time is very, very important. And then coming to supplements. Supplements somehow in India, in my practice at least, I see patients are just doing their own vitamin D, vitamin B12, and there's multivitamin on a day-to-day basis on 1 mg or some Instagram and vegan, this, that. So nothing should be without medical supervision and our we telling them what should be the dosage, and of course folic acid. And the new thing that we tell them is this coenzyme Q 200 mg TID, but there are no studies to say how much is good enough or how long is good enough. It just improves the mitochondrial quality of the egg. So that's about supplements, and all supplements is when you see the shortage and then you try to address it. And coming to exercise, exercising 4 to 5 days in a week is good enough, and not make the patients obsessed with weight loss or how much to exercise. And when they exercise 4 days in a week, 20 minutes of aerobic exercise and 20 minutes of strength training is good enough, because many studies have shown that any kind of aerobic exercise beyond 25 to 30 minutes will only harm your muscles and joint. It does not have any additional gain beyond this point. And muscle strengthening, anything against resistance exercise is recommended so that they maintain a better metabolic rate. And so even if they get a little irregular about exercise, that's fine. And also so that all the toxins are flushed out. So exercise is very, very important. And for women, the gut, the brain and the reproductive system are well connected. So what they eat and what they think and their emotional status is very important. So women can start with just 1 or 2 minutes of meditation or mind calming music, and start, if we tell them to start with just 2 minutes, 3 minutes, that's how, mindfulness starts, and that really helps them to take on stress. So stressing on healthy lifestyle where they keep away from negativity in terms of food or in terms of emotions is very, very important for a good outcome for pregnancy.
Thank you, ma'am.
I don't know, for the last, I mean, how are all of you now? For the last, I think, 2 minutes, all of us have been remembering how many of our cells are damaged right now.
I saw the moment Rajeshwari said 8 hours of sleep, I saw Palani look at everybody. And I saw a bubble float on top of her head saying, timely sleeping, 8 hours and eating on time, bloody shit. No timely PG or register is going to ever have a baby.
And the other talking to me, right?
I saw the bubble man.
And Dr. Swapna, when we start, this recurrent pregnancy loss is one of those problems where with the first time around, whatever it is, second time around, whatever it is, she gets progesterone, she gets bed rest. Third time around, she gets more progesterone, more bed rest. And by the time she's on to the time when we know what is the cause was whatever translocation and you do PGTA and this, that and the other, she's already at risk because of the endocrine causes. Because that has now happened in the process of this whole process. So I think again we cannot look at the whole problem in silos. We have to keep everything going on at the same time.
Yeah.
And then, and I think even the doctor needs that advice what she gave, because by the time you are dealing with a patient like that, the moment you see that name on the OPD sheet, you take another cup of coffee. I think that's what the doctor here is very mindful to say.
And also Rajeshwari is dissing our Hyderabad youth habits. But then I have to share with you that the girls and the boys who are coming now, preconception, some of them come for preconception counseling, and I'm like, do you need to tell me anything? yeah, doc, we're taking some supplements. So I said, what supplements are you taking? Oh, I have my skin supplements, I have my hair supplements, I have my joint supplements. I'm taking retinol, I'm taking glutathione, I'm taking for my skin collagen, divine collagen. And then I'm taking magnesium because I want to sleep well, then I'm taking something else.
You forgot vitamin D.
That anyway they're taking.
Obsessed with
That anyway they're taking. So other than that, there are only supplements they're taking, and none of them are of medical grade. So I really don't know what's going into this. So yeah, in Hyderabad is like a supplements.
I'm obsessed with organic.
Definitely.
Really,
Sure that, yeah.
That's why it's so expensive, man. Sleep is not only doctors, IT people now, we see they sleep at 2 a.m. 2 a.m. is early.
No, they're sleeping through, but they wake up at 12 p.m.
Get the
na?
point.
So Pallavi is right, I agree with Pallavi. Gynec, PGs and registrars are never gonna have kids.
They come to this conference,
No,
nobody.
I think people will sleep, they wake up late. I think they sit at 2 a.m. and eat a whole plate of biryani and then they go to sleep. Mane kaadu biryani ledu to sleep.
Again, 9 o'clock OPD, we need to come back. So how is it possible to sleep right now?
I saw the problem. That's why we need a platform to speak up about our lifestyle.
But taking about the IT, one of the other things that we keep hearing is the effect of radiation. So what's your take on that?
I don't think it is a screen radiation which is affecting them, it is the bullshit of
So this is being a legit question by so many people.
No, it's a bullshit of
My wife is on laptop every day, ma'am. In the night also, how will she get pregnant? If she gets pregnant, how will the baby? So
You mean she's on the laptop so there is no intercourse? That is the point there. No, that also is a point, they are very busy, you don't have time for intercourse, I can't tell you why.
they just want one day, ma'am, to have intercourse and get pregnant. I told, don't get pregnant because if you have a baby, you need to take care. Just leave it alone.
No, but then if I have a cute baby, so see on TikTok, so please, don't deny them.
So last question on the lifestyle and age is what about paternal age? Is that a factor?
Yeah, so unfortunately, there's no one figure where we can call a man old.
Madam, 80 years old, ma'am, now the new thing. So,
But
They have the figure for women.
definitely.
Women are forever 21. Men over 21 are good. How the tables are.
But the good thing is they never age beyond 21, I mean at least mentally.
Mine don't be my life over 16 only.
we are for 16 only.
I feel like kids.
How many children do you have? 3? Is it a man? 3. Better age also, definitely yes. But what age maybe over 50? Over 40?
40
40. Yeah, more DNA fragmentation.
No studies as such till now, but of course we have seen a lot of or so there are no studies to find that, but definitely when people are going for IVF, then definitely the sperm quality is affected and also testicular function is affected, DNA fragmentation is more. So these children have, whatever will be the result of poor egg quality, the same thing comes with the sperm quality too. Just that the number is not there, but otherwise.
So do you also work up the men then for uniform fragmentation when you see like
Okay, I will make the men in the room happy. There is one female who had a child at 82. Spontaneous conception. Old time Picasso also had something. Yes. Robert De Niro had 82. He is 82, he had a child with spontaneous conception. So men are forever young.
So I'm going to open questions to the entire panel, and these are, not particularly related to RTA, but more about practice and especially genomics in reproductive biology. So one question for everybody is, what are your recommendations for couples who are planning the first pregnancy? Healthy couples who are planning the first pregnancy. Genetic and non-genetic tests that you might recommend, because a lot of people come in preconceptionally asking, we want a healthy child, what can we do?
So I think it's first and foremost a very progressive step for any couple to come for a preconception counseling, and that's happening, which is a good thing to happen. Like all of us discussed, and Dr. Swapna particularly mentioned these lifestyle supplements which people are taking, skin treatments and all this. So it should actually happen from those parts also, whoever are the professionals prescribing those things, they should tell people in the reproductive age group that there are certain things which you need not be taking if you're planning a pregnancy. So a preconceptional workup gives us a time to sort out all those issues. Because even if they are completely normal, completely healthy, they may be into some of these lifestyle interventions which need to be changed. In terms of medicine, we definitely ask for a basic blood profile, a complete blood picture with HPLC. That is a screening test for hemoglobinopathies. That should be done. Because if you do that, you sort out a lot of issues for the future. Your sugars, your thyroids, and like I said, the rubella IgG. These are the basic, and a blood group, of course, for that matter. These are the basic preconceptional tests that we ask people. We don't go for genetic tests for anybody and everybody, even if they are consanguineous. Nowadays, in this part of the country, there is a lot of consanguinity, so they come and ask. So I take the approach, like how Dr. Swapna said, discuss with them that if you do not have a consistent family history of a particular genetic disorder, and consanguinity is running in your society for a long time, very rare chances that you may find something. But it's not unknown, so should you want, there is this, we call it the extended couple carrier screening. You can go ahead and do that test, and if there is something, then we can discuss if there is prenatal testing available, but not randomly. A couple karyotyping without any background we don't offer. So the basic preconception tests are those, and we tell them to maintain a healthy. The other thing we forgot, that even in radiology there used to be a 10-day rule, where we would not do a radiological investigation when the woman could have been pregnant. And that's another set of people who keep coming to us that I had this CT scan and now I'm pregnant, I had this X-ray and now I'm pregnant. So all that can be done in the preconceptional clinic. So if there's anything else to add.
I agree with everything.
Reduction of weight. If they are already obese, reduce the weight and then you can gain that weight in your pregnancy. That's what we
One would say work on reducing the weight. Otherwise, then the weight becomes one thing, and then say, I am losing weight, I will come back after 6 months. And then you will gain 5 kgs more after 6 months.
That's practical advice.
Yes. So work on exercising, do moderate exercise. I think what the new generation needs is moderation in life. It's either all or none, the pendulum varies from here to there. And I also tell them, start having intercourse, have fun, enjoy the process of getting pregnant. Because as Pallavi said, they're so busy partying and so busy doing everything else that, we've not had time, madam. They're very busy, we don't have intercourse. So I tell them first, work on your lifestyle, have intercourse, 6 months nothing happens, then come back to me. So, that's also becoming a problem now with the youngsters.
But the youngsters are really not enjoying anything in the true sense, because I see in normal delivery, I'm delivering the baby, and generally couples who are chilled out, they're like holding each other's hand, or kissing around the forehead, something they're enjoying. And I had this set of patients who are like, delayed cord cutting. Like this, delayed cord cutting. And then by the time I'm doing that, it is my job, I do it every day. And by the time I do that, they're like, what is this? You say, go there. And you have to. And after that, they're still suturing, we start doing golden feeding. I am paid. I'm overpaid for doing my job. I am not enjoying your pregnancy.
To be with a woman in labor, ma'am. Recently, one of my patients, they didn't have sick. Hardly 3 to 4 hours, the husband didn't want to sit with the patient. I'm too busy, ma'am, I'm too busy. I told Virat Kohli left entire England series to read it. This example only, ma'am.
This is not judgment, there are some couples who says, I tell them, both you go together to the working class. The husband says, ma'am, there's a lot of pain I can't see. I tell him, yeah, no judgment. If you can't see, you can't see. But if it's okay with your wife, don't do it. I'm okay either way. See, there's a lot of judgment and expectations going on. Why do you have to be cool and fit into that? Why can't you be a round peg in a square hole? You can do what works for you. Just because my husband works in the same place, never came for an annual checkup. So I have to be living there. So it's okay if it works for the couple, it should work for the couple. I should not fit into some preconceived notion.
Definitely. So that, takes me to the last question, which is about.
Just to add on the genetic part, so the best genetic test, I would say the first thing, or the most important thing is a 3-generation pedigree. Please don't forget to take the family history because that will give you so many clues in the preconception period. So many times it happens that when something comes up in the scan, then the history is taken and then you find out that yes, there was a previous baby with something similar or some other baby in the family or person having a similar problem. So those are things, the right time to intervene, the right time to do the workup to the couple is in the preconception period. That's a golden period actually where you would prevent many of the recurrent genetic issues, provided that you take a proper history. So taking history of at least 3 generations, so we call it as a 3-generation pedigree, that's the best genetic test you can do. So once you have that, then depending on that, of course, the couple may need further workup. And as Dr. Chinmayee mentioned, so we need to do thalassemia carrier screening for everybody. So 5% of Indians are carriers of thalassemia and they are all asymptomatic unless we do the testing, we don't find. And this could happen even for non-consanguineous couples. So couple need not be consanguineous for the baby to have thalassemia. Because 5% Indians are carriers, so just by chance 2 carriers can get married to each other. And now we also, so our Society for Indian Academy of Medical Genetics, so in fact now we are recommending that every couple should also get carrier testing for spinal muscular atrophy. So this is another common autosomal recessive disorder and 2% of population across the world. So this is not India specific, it's a pan-ethnic condition. So 2% of individuals across the world are carriers of spinal muscular atrophy, which is a very disabling and potentially lethal neurological condition. So for that also carrier testing should be offered now to couples. At least one partner we should screen because it's a little bit expensive test unlike HPLC and it's not that freely available, but most of the genetic labs are having it. So at least for one partner we do it, one partner is carrier, then we can do the second partner as a second type test. So at least these 2 common autosomal recessive conditions every couple should get screened for, and the right time is the preconception period. And then the rest of the testing like the expanded carrier testing could be on a case-to-case basis depending on again the first important thing being the family history and the second thing being consanguinity again. So although we don't have any recommendations that consanguineous couples should undergo expanded carrier screening, but it should be discussed as an option for them because if we see overall like the risk of a consanguineous couple having a baby with a genetic condition is twice that of any other couple, but if we see in the terms of magnitude it still comes to around 5%. So overall, if we see in population, the chance of a baby being born with a genetic condition is around 2%, and for a consanguineous couple, it's double, so it's around 5%. So that magnitude, because many couples are coming, so for our clinic, they are coming now in preconception period. In fact, they're coming in pre-marital period, as one of the cases you showed, where they're very concerned, they're really scared that I'm going to marry in family. And then what's going to happen, and then on the basis of the genetic test, they want to decide whether I want to get married to that person or not. But we need to tell them the overall magnitude. It's just 5%. 95% of babies born of a consanguineous couple are still going to be healthy. But if some couple wish to even, make kind of further lower than 5% risk, then one way is to go for this expanded carrier screening, whereby you can screen them for mutations in various autosomal recessive disorders. Again, for that there are different panels which are available. Unfortunately, those panels are based on American data and we don't have Indian data saying that what are the commonest conditions in India, what disorders should we be screening our patients for. So we don't have that information. We are working on that to come up with all that data. So our society is working in collaboration with other research teams and all to come up with that data, that what is the carrier frequency of various recessive conditions in India, so that we can design an India-specific carrier screening panel. Till then, we can at least go for a clinical exome sequencing or one of the larger panels which includes some common things like congenital adrenal hyperplasia, deafness, and also cystic fibrosis. So these are some of the disorders which we know are equally prevalent even in India. So at least make sure that whatever panel you opt for, that includes at least these conditions.
Ma'am, so I think more about what we have heard from the clinicians. The SMA is something that we have routinely been offering since AIGM has recommended that. But I definitely get a lot of pushback, and I think all of us have seen that amongst the genetic counselors. Is we get a lot of pushback from clinicians saying that why is this one extra test that we need to order? It's expensive. There's no family history, and we've tried explaining how beta thal is a common genetic condition. SMA is debilitating. It is common. Please screen for it. And unfortunately, that's, I think the acceptance is going to take some time.
It takes time. Yeah.
See, for a couple who comes of preconception counseling, giving them that information is valid. Choosing to do the test or not to do the test on the basis of cost is again something
Absolutely their choice.
the person who pays has to decide. When we explain, it sometimes the cost is a very relative aspect, and it's usually not the cost of doing the test, it's the cost of doing the test that you pay the price for. So you need to be very certain in telling them that look, you want all this information. And yes, genetic tests are expensive, but they are only more expensive than the other common tests that we do. But when it comes to treatment of that condition, and a condition which has no treatment, then this cost is really a very moot point. So driving something across in terms of genetic, and you can't always be saying that we bring the cost down, because that's not an answer to everything. You just can't bring the cost down for everything. You charge a certain amount. If you bring the cost down and say I'll still maintain quality, I'll question you, why were you not doing it in the first place? So if you are charging something, be responsible for that charge. Charge whatever it is reasonable, but give them the correct answers. And to choose genetic testing is not going to be a very big option later on. You will have to do certain things, because time is limited. It's a fact. Women were getting pregnant at ages of 18 to 20. Now they are getting pregnant after 30, 35. Because you want them to get educated, you want them to get some. All of us here, if we take our average age of when we wanted to have our first babies, it was much later than a lot of other women who didn't go into this profession. And the biological timeline is going to remain the same. The menopause age is not pushing any further. So if we have to have our reproductive lifespan in that given period, we have to accelerate the number of tests or the number of things that we are going to do. And I don't think we should be apologetic about it. In fact, it's a good thing that why was the definition of recurrent pregnancy loss brought down? I mean, from 3 it's come down to 2 actually. The X-ray started suggesting that
X-ray is agreed to 2. RCOG is still on 3. So what if after 1,
but again,
I would not have.
And RCOG has to deal with the challenge of providing it to a number of people. So for them, having a definition of 3 works for their health system, because otherwise the government has to take responsibility.
Because the moment you bring it down to 2, the numbers double.
So for them it's a policy decision. But for us, if there is a couple who've come first time and say, look, we want to have it all, they can have it all. Why should we stop them?
And then they can have testing for DMD also. Na DMD is so common in India. We can also test for DMD.
If somebody specifically wants a test for DMD, it's common, but then there has to be some history in the family to justify it. We don't feel so pushed towards as DMD because she will have a history of male members in the family suffering from a similar kind of disorder. If that is not there and she's just psyched about DMD for whatever reasons, I would send that person to a professional genetic counselor so that they draw that whole pedigree thing and tell them that look, we don't see anything. Still she says, no, doctor, I saw that friend of mine, she had that and I want to really get it out of my mind. Test. What will you offer? You offer a test for that woman alone.
And that's even de novo mutation. De novo is very common now. Sometimes non-consanguineous family, non-consanguineous couple without any family history, and we see so many DMD patients. They are equally debilitating, just like SM.
I understand.
So can we
But
do?
when we look at, probably you work with a center where there was a series of patients with DMD at that point. But let's ask the geneticist here. Are you happy with the blanket DMD testing for everyone?
So what we do is that, I mean, for everybody it's SMA and thalassemia, but when a couple is opting for an expanded carrier screening, then as part of expanded carrier screening, DMD carrier screening and Fragile X carrier screening, these two are also offered. So in fact, many of the panels do have these conditions incorporated, commercial panels, or you could offer them as a separate test if you are going for a clinical exam. So these, whenever any couple goes for that expanded carrier set, then DMD and Fragile X carrier screening is also covered. And of course, these are for the mom.
So just a comment to add. So as rightly said, that one is consanguinity, another is the family history, because we know that within the region the marriages have happened, and we know that yes, there is a a family history there. But then what's happening now as well is that east is meeting west and north is meeting south, which has never been experimented or never been checked into, right? But nowadays those occurrences are going to increase only because of the cosmopolitan cities which we are living. And that is where I think what IFG is trying to do is to make the carrier frequencies are very important, and then design a India specific panel. I understand that all that 4,000, 5,000 or 7,000 rare diseases are not going to happen in India. Out of the 400 are already known, but then to understand the carrier frequencies would actually, and then databasing them, and then the genetic council is knowing that okay, if you are coming from this region, the carrier frequencies of a particular disease is high, then we can choose that to whom to give the ECS or
So that's what we are working on, but that's going to take a while.
I understand.
Cover the whole of India, and the point that we are so diverse to finally how much information eventually we will really have is still a question mark.
Absolutely.
SCA is one of the examples.
So I think the discussion that we had between two elite geneticists now. So what we are saying is you have a Punjabi person marrying a Tamilian person, you have a Sindhi marrying an Assamese person, and therefore you don't know what ethnicity you have to deal with in terms of the genetics. That's one challenge. The other challenge is that whatever carrier frequency, 2%, 1%, anybody could be a carrier for that matter. So that's what our colleague was saying, that we need to work on that. So I think when you generate an India specific panel, probably you have to give us that recommendation that okay, it's all right to offer it to everybody. The problem about offering again is that there is a level of inadequacy that the patients feel if they are not able to take that. What happened with our stem cells at one point, what happened with a lot of other tests. If a couple are not able to afford that extra in their care plan, they start feeling, are we not doing it? They start feeling guilty. And then we have to justify whether that added advice, because if we have advice, then it becomes a very, oh, you can do this also, you can do that also, you can do that also. But then we have to draw the line somewhere. So as of today, I think whatever we discussed, plus SMA, if the SIMG is recommending that, but then if they're recommending it, we have to find out where all it's available and how much, what is the turnaround time and how that's going to be useful. For the others, until we have that India-specific panel, I think we just have to wait.
Yeah, that's true.
Unless there is family history or...
Family history, no question, family history.
So as a routine test, we are not ready. India is not ready to offer it.
When we have the best genetic screening is a good history. So, and that we have stopped taking. We don't ask people that are there children in the family who had problems. have you, because very many times after the anomaly scan, the couple asked, is the ear okay? Why are you asking that? Because somebody has a hearing defect, somebody has something, then they come back with that history. So unless you have asked this proactively, they cannot, I mean, they will not retract that statement later. But then if you don't ask, small things they won't tell us. And they will tell, we had a couple of cases where after a lot of many interviews, they said that father has some twitching in his hand. And then this was looked into something else and something else and something else, and that was manifesting as something in the fetus. So a detailed history is very important. Pedigree is something I completely endorse it, but I don't know, Dr. Shagun, there is a mental block to draw a pedigree. How many obstetricians here are happy to draw a pedigree?
We want to also, they won't tell us. Hardly we come to know. Or when they are throwing fits or something.
But if I tell you my history, will you be able to draw my pedigree?
Exactly, but
Right now,
at least,
you can write the lines correctly, where one line, where two lines, where something.
Okay, I should stop putting the fundamentals of our education.
No, why I'm saying this is it. Dr. Shagun, you should take this up as a basic, just like we do ultrasound awareness, please do a pedigree awareness. She is with us, she's the Secretary of Scientific Medicine, Telangana, and we should now do this because this basic pedigree is something, unless we draw it, we don't ask how are your sisters and brothers. How when you say any family history of problem, no, madam, everything is fine. But your sister died of a myocardial infarction at 22 years of age, you don't know that. The brother died of some kind of, my brother is on wheelchair, this information comes much later. So, until we draw that, how many siblings are you this side, that side, and once you do that, you automatically get a lot of information. So I think that pedigree, just like we do ultrasound awareness, everybody now knows how to do it. I've done my job, you do yours. So that
I invite whoever is ready to come to our department, and then so we have observership options. If you are ready, please approach me. You can approach our team. You can write a mail.
or we can do some webinars also on that.
That can happen.
But please do, because that genetic screening is very important and that has to start in your clinic. Because everything said and done, the obstetrician is the center point who can make a change in this practice. It is not the fetal medicine person, it is not the geneticist, we are all in the periphery. Everything that we say, the patients will say, I'll go back and check with madam and then tell. So if madam is convinced, then things will happen.
Don't worry, the sleep is gone more.
She can't sleep, she's lost herself will be damaged.
Very nicely, she's done the whole lot of work.
take to write a ABC card the next time I'm 50.
Yes,
Patri, and then we will help you with the history.
I was reading talk about women's health prophylactic testing, and I was talking to some software group, and then I said, you have to do a pap smear. So one girl called, stands up and says, yeah, you are telling to do pap smear, but how, my mother is 50, you want me to get a pap smear done for her? I said, yes, 50, if she's not done till now, absolutely yes. No, but who will do? I said, take her to a government clinic. No, but they charge money, no? So I'm going to charge money, no, for general public. Then I said, okay, Pablo, bring your mother free. Take on my software, hardware, AMC for free. We'll do barter system. Now, so there is all these, there is a financial constraint.
Especially for medical field, they have
Yes.
lot of financial
No,
constraints.
everything has to be free, ma'am. We are noble. So I said, why do you expect that it has to be free? So she said, you're noble profession.
I agree with the noble woman, as long as If we go to the supermarket, everything should be free for us.
Education should be free for children.
Everything should be free for us. We will give free service if everything that we get is free.
Yes,
Agree?
So doctors will work like old-time Vedic time doctors. Everything will be barter system for us.
The world would be better if it was a barter system.
So financial constraint, and as you said, more and more work to just get the obstetric history in recurrent pregnancy losses. Every time the MBBS girl will be told something different, then the registrar will be told something different. Then they come to my table and then maybe 5 points I be adding in that, and I will be looking at the registrar. And another registrar says, ma'am, I asked, they didn't tell.
They won't tell ma'am.
But
On the table something else will be there.
In my life, I am never going to be the senior most registrar. That 5 will go to Sapna Madam's table and 3 more will add there. On that table. So, that was
There is also a very sinister possibility nowadays, people are faking their history.
Yes.
I have had this experience several times where they have not given a history of a previous child having a similar problem. We had a case with a child having a posterior fossa cyst and everything, and the previous child on our history was dead with gastroenteritis. And then by the time I finished all this counseling, I got a call from somewhere else, oh, is this a recurrence? And then half of the family members had already gone to meet the other doctor. And then I came to know that this is already worked up. There is a history of juvenile and there was some of the other workup done. It was a known case. They have just not given that history.
वो बोले तो लेडी को भी वही बोलते हैं डॉक्टर. इसलिए वो नहीं बोला. इसलिए वो नहीं बोला.
The DNCs, previous DNCs, everybody is a crime.
While all that we are discussing is good, ultimately it will come down to your communication with your patient and your effort of taking that history. So I think taking a good history is important. If they have given a fake history, so be it, because they sign whatever we take as a registration form, they sign it. So I had that in front that you've written there that the child has died of gastroenteritis, because I actually asked, I said, how did a child die of gastroenteritis? I mean, in today's day and age, it's very difficult, but they still worked on that story and gave me something, and we thought it's sensitive not to ask anymore, and the fact was something else. So,
In terms of cost, what you are talking about, so if at all any POC sample comes after RPA and all, so because the CME costing testing a field on the RPA is costly. So if the patient is not ready to pay the money at that particular time, what is the sensitive way to suggest that? Is it a sensitive way to suggest them to go for normal DNA extraction, store the DNA for the next pregnancy to come and decide on that time, that has to be lesser.
absolutely, because storing the DNA is a very logical way to do things. Also because sometimes the patient wants to test. They want to pay, but they can't pay right now. See, everybody's income is of a different thing. When you are talking about a miscarriage, you are also talking about a follow-up admission and a procedure in a hospital for which they will have to pay. And that cannot be postponed because that has to happen now. Whereas they want to do the genetic test, but they can't pay right now. So then you do the DNA storage and give them the option of doing this test after 1 month.
All the labs actually provide storage services.
Yes.
Yes. So that can be something.
That is a part of our regular testing protocol, that is a part of it. So if you want to do the test right now, you can do it. If you are not sure, at least store the DNA and we'll do it later. That's what Dr. Shagun was suggesting in the first place. But her reasons were different because they wanted to withhold the test till that time. But suppose even somebody wants to do it but doesn't have the money.
Commercial aspects में what are suggesting?
What does storage cost?
Around 1,500.
700 in our hospital.
Some of them also decide on the tests and logical reasons. They are just worried with the miscarriage or deal with that and then.
1,500.
Yeah, 1,500 across the
I want to thank all of you on the panel. This was one of the best panels I've had here. Thank you all for staying.